Assalamu alaikum, dear guests and speakers. Good evening, everyone. I hope that you can see me here on the screen. My name is Muhammad Mukhtar. I'm the head of the medical affairs at Leo Pharma, UAE and Saudi Arabia, speaking to you from Dubai. It's my pleasure to be the moderator of tonight's webinar. And on behalf of Leo Pharma, we wish to extend our warm welcome and thank you to all participants and the guests attending this webinar meeting. Our topic today is addressing one of the common chronic skin conditions worldwide, which is atopic dermatitis. And our guest speaker today is Dr. Sri Kumar Guturu. And Dr. Sri Kumar will provide us with an overview about how to optimize the use of topical corticosteroids in atopic dermatitis. Just a little housekeeping before we get started. At any time, if you have any question during the presentation, please type your question into the question box at the lower right corner of the webinar screen, or use the raise hand option, and be assured that we will have adequate time to answer all questions by the end of the presentation. One important notice to all participants is that this webinar is CME accredited. So I'd like to highlight that the link to collect the CME points will be shown on the screen by the end of this webinar, and all attendees can access this link to answer few questions to get the minimum score in order to be awarded with the CME hours. And for those who will not be able to do this after the webinar, the link will be shared by email to all participants who are registered in this webinar meeting. I'm really optimistic that this webinar will be a good opportunity to all of you to acquire new experience and new knowledge. And I would really encourage all of you to actively participate in the discussion and following this presentation. Now, allow me to introduce our guest speaker today, Dr. Sri Kumar Guturu. Dr. Sri Kumar is consultant dermatologist and venerologist with more than 30 years of experience in dermatology. 20 years of them were in UAE. He is the head of dermatology center in Amber Clinics in Dubai and the medical director of Dr. Joseph's Polyclinics in Al Karama, Dubai. Dr. Sri Kumar areas of interest in dermatology are the immune-mediated inflammatory skin conditions and biologic therapies. With that, I'd like to invite Dr. Sri Kumar. Please, doctor, the ground is yours, and may I invite you to begin your presentation. Thank you.
Assalamu alaikum, everybody. Thank you for the very kind introduction, Mr. Muhammad Mokatar. And it's really a pleasure for me to share my experience. And I'm sure the audience are equally excited. After all, we all signed up to medicine because we want to make a huge difference in the quality of life of our patients. And what more condition than atopic dermatitis? In a single sentence, atopic dermatitis is the single commonest cause of non-fatal inflammatory skin condition, causing a huge burden in the life of our patients. What do I mean by life of our patient? We all know that atopic dermatitis or eczema starts almost from birth, and many a time it can go on and on even into adulthood. It robs the quality of the life of an individual, be they children, be they adolescents, be they adults, be they of marriageable age, and even nowadays, even in old age. In fact, I would say that an atopic individual's quality of life is so bad that any intervention which can improve the quality of this really dreadful condition is very welcome. Therefore, with this short introduction, it is very obvious that we are in an exciting era. We have a plethora of new agents coming up. The research into atopic dermatitis and our understanding of the immunobiologics involved And the huge improvement in the way we can treat has actually exploded into an era of excitement for us, where we can actually produce a huge difference in the quality of our life of our patients. Still, we know that topical corticosteroids and topical calcineurin inhibitors are actually a mainstay in the treatment of this condition. And in fact, even many of the modern biologics and JAK inhibitors and all of them which have come up have studies which show that they are compatible with the use of topical corticosteroids and the JAK inhibitors too. And we know that we should be actually very much aware about how we handle these agents. So it's very important for us to know how to optimally use a topical steroid in atopic dermatitis. So with this short introduction, let me get into my talk. So the aim and objective of my talk is to discuss optimized use of topical corticosteroids and calcineurin inhibitors in atopic dermatitis. We all know that with the moment we mention the word steroid, many patients have a huge dislike for it. There's a phobia. This phobia has been actually accentuated by many social media and real media stories, and in fact, the widespread awareness of the side effects of steroids. But please remember that if judiciously used and if we choose the right agent for the right location and the right time, these agents produce a huge improvement in the quality of life of our patients. And we should never make the mistake of not choosing the agent at the right time. Therefore, we need to understand how to use topical corticosteroids and calcineurin inhibitors in atopic dermatitis. So, of course, the learning outcome would be that at the end of this talk, we would have a better understanding about atopic dermatitis itself, its prevalence, negative impact on quality of life, itch, sleep, skin pain, and of course, the huge social and economic burden and the mental burden that it causes. The complex pathophysiology of atopic dermatitis and the rationale for optimizing the use of steroids, topical steroids, and calcineurin inhibitors in the same. And not only that, like I just said, the importance of management of atopic dermatitis with the new and exciting tools, especially combining them with the traditional topical corticosteroids and topical calcineurin inhibitors. Therefore, we actually are in a really exciting area where breakthroughs in translational biology with the discovery of new molecular targets have actually helped us to make a huge difference and predictable difference in the quality of life of our patients. With the exciting developments, we actually need to further be careful about how we use our topical corticosteroids and calcineurin inhibitors. I will start my story with a recent patient. See, this was an atopic dermatitis patient who was about 20-year-old female. She had been having eczema right from the age of 18 months. We all know that it's very common for atopic dermatitis to start very early in life. She had had a fluctuating course with flares and remissions and all that. The interesting thing was that she had a pretty long remission during her childhood and adolescence, which was relatively tolerable, I believe. She, of course, had been treated for asthma too. We all know the importance of the other type 2 conditions, the so-called associations of atopic dermatitis, asthma, hay fever, and food intolerance and things like that. She had tried everything, including the topicals, topical steroids, topical calcineurin inhibitors, moisturizers, the usual stuff, and she had even tried homeopathy. Actually, this is how she looked when I saw her on the first day. The story was that severe exacerbations had started by the time she came to her grade 12 board examinations. Stress, we all know, can actually make the eczema worse. And when I saw her, she had a BSA of body surface area of 20, the EASI, that is the Eczema Area Severity Index, which was 32.8, a physical global assessment of very severe 4, a SCORAD of 72.05, a POEM of 28, a DLQI was 21, the HADS anxiety was 13, and depression was 8. So I had actually recorded almost most of the parameters required to not only assess the severity of the condition, but also help in actually having an individualized eczema action plan for her, and to have shared decision making setup. So what was the issue is that we had a severe atopic dermatitis in a 20-year-old with no response to the standard topical treatments. Obviously, she was clearly a candidate for systemic therapy. So what systemic therapy? I did have almost half an hour discussion with her, and we arrived at a shared decision-making point. I did explain to her that atopic dermatitis is a chronic relapsing condition which can last lifelong sometimes, that it robs the quality of life. She already knew all that. And I told her that we know the newer agents are pretty effective. So I offered her the two newer agents. One was dupilumab, the other was baricitinib. And I also discussed a possible treatment with phototherapy and cyclosporin with her. She refused phototherapy because her exams were coming up soon. And cyclosporin she was not very keen on because of the current COVID era and pandemic. And she was a bit hesitant about dupilumab because she had some needle phobia. And she really wanted an oral treatment, and she wanted it to work fast because her exams were coming up. So with all these discussions factored in, this frustrated, depressed person in whom almost nothing seemed to be working, actually ended up with a rapid and significant improvement. We started her on baricitinib, 4 milligrams once daily, of course, along with topical corticosteroids and topical calcineurin inhibitors. We all know that most of the studies have actually used these in combination, and the results are far better in this combined treatment scenario than as monotherapies. And the itch NRS and the sleep NRS showed a rapid and minimally relevant clinical difference even within a week almost. And there was a rapid improvement in the quality of life of this patient. So a significant improvement in lesion extent, severity, itch, sleep, quality of life indices, and she tolerated the medication pretty well. This is the actually analysis that I had. The EASI, that is the Eczema Area Severity Index, dropped from 33 to 6 within a week, which was pretty impressive. Pretty fast improvement in area and severity. The score had also dropped pretty fast. The PGA from 4 to 1, which is a clear-cut big difference, clinically minimal relevant improvement observed. The POEM dropped very fast. The ADCT. Now, we know that the number of parameters that we have for assessing the severity of atopic dermatitis is huge. In fact, there's an organization called HOME, Harmonizing Outcome Measures in Eczema, which is actually trying to make more simplified assessment tools, which can not only assess the severity, but also assess the amount of control we have. And one of the tools is called Atopic Dermatitis Control Test. So this showed a very clear improvement from 20 to 3. And her anxiety and depression improved a lot, and the quality of life improved significantly. These are the before and after pictures, the before and after pictures, and the before and after pictures. So to be frank, we have tools now which are pretty effective and which can give a pretty good result, and if used judiciously, can give a long-term disease control. But that doesn't mean that we move away from the topical corticosteroids or the topical calcineurin inhibitors, because we should know exactly how to use them in this new exciting era of modern therapy too. To recap a bit about atopic dermatitis or eczema is possibly like I said, the commonest non-fatal skin inflammatory condition, which the biggest burden on the quality of life on individuals. The prevalence varies right from 2 to 20% in children to maybe even up to 10% even in adults. And the severity also can be anywhere between 10 to 40%, and some figures say 4%. See, all the statistics about the prevalence and the incidence, they need to be taken with a pinch of salt, because the diagnosis of atopic dermatitis is basically a clinical diagnosis. The gold standard is the expert opinion of an expert dermatologist, of course aided by a set of criteria. These criteria actually are formulated for different scenarios. Certain criteria are more sensitive and specific for population studies, and there are some criteria which are more useful for individual cases. And even the sensitivity and specificity of this criteria changes depending on the background prevalence of this condition in a community. Therefore, actually, many of these statistics vary depending on how exactly the analysis was done. Of course, atopic dermatitis has a multifactorial nature. We all know that there's a huge genetic background. We know that nearly 75% of twins, there's a concordance of 75% in twins. And we know the strong family history of not only atopic dermatitis, but also of asthma, champion sneezing issues, and food intolerance, and classical type 2 issues in these patients. And we know the high prevalence in the urban communities. We know that the prevalence has been increasing almost exponentially every decade. It may be plateauing in the bigger cities, and of late, maybe the rural areas seem to be catching up. But whatever it is, we know that there is a genetic background, there is a barrier defect in the skin, there is an altered microbiome which the skin has to handle, and there is a massive abnormal immune response in the skin. The way you put it, whether you talk about it as an inside-out hypothesis or an outside-in hypothesis, and how you actually project the whole issue of atopic dermatitis and its causation, actually is depending on how a person looks at it. But these are the basic fundamental characteristics involved. We know that the two major issues are a skin barrier defect and a dysfunctional immune system too. We all know that there is a genetic defect in quite a number of patients with the filaggrin gene, but it's not just the filaggrin gene. Not everybody with atopic dermatitis has an impaired filaggrin gene. The number of genes and the loci which actually contribute to atopic dermatitis seem to be quite huge. Not only are genetic loci found in genes which determine the epidermal barrier, but also genes which determine the immune mediatory response, which tweak it more towards the Th2 response, are very important in atopic dermatitis. And we are probably dealing with a highly heterogeneous condition, and you may have different ways in which it presents. So we know that the most common presentation is right from childhood. Nearly 50% of atopic dermatitis patients develop it within the first year of life, right in infancy. 95% experience it below the age of 5 years also. 75% have spontaneous remission before adolescence. These are relatively interesting statistics, but I would say that I can put the same thing in a different manner also. There are different projections. You have an early onset with an early improvement. You have an early onset with a fluctuating course. You have an early onset with persistence to adulthood. We have a late onset, which can come even in adults above the age of 20 or even very late in life also. So you have different kinds of presentations of atopic dermatitis, which makes it quite interesting. And the jury is out to see whether we can actually have any specific biomarker which can predict the outcome in a patient. We all know that the more severe atopic dermatitis, the more severe asthma, the more severe hay fever, and the earlier onset patient may possibly go on to have more severe atopic dermatitis in adult life. But then these things are not absolute. So actually, a lot of research is going on to see whether we can identify any biomarkers for not only the diagnosis, but also for the prognosis, and also biomarkers as a treat to target in future. This is very interesting. Of course, the clinical manifestations of atopic dermatitis are pretty classical. We know that there are essential features: no itch, no atopy. We are obviously dealing with an itchy skin condition. Of course, there's an eczema. Ek means outside, zema means to boil out. So you have a eczematous lesion. You have a characteristic morphology and distribution depending on the age, infants, children, adults. So in infancy, it's more of a subacute or wet eczema involving the face, the neck, the extensor surfaces of the body. As the child grows up, the flexor involvement and the classical features in the body folds, the neck and all that appear. The interesting thing is there's a sparing of the armpit and the groin. And in adults, it might localize into a hand eczema, or you may have a head and neck type of a presentation. The older a patient is, the more chronic the skin lesion starts looking, with more dry skin inflammation and lichenification, replacing the wet eczema that you see in early childhood. Of course, these are not absolute. You can have a wet eczema even in an adult. So even though we speak about these as classical presentations, we know that it can look different sometimes. Talking about the prevalence of atopic dermatitis in children about 14 and older, this is a map showing you the prevalence. Like I said, the prevalence depends a large extent on how exactly this was calculated. Nowadays, they are trying to do telephonic inquiries to see whether a patient has a itchy skin rash and a history of asthma. If you use something like that, you might end up with a higher prevalence. The prevalence depends largely on what kind of system was used. Regarding the impact on the health-related quality of life, believe me, you don't need to look at this slide at all. The impact of atopic dermatitis is tremendous. Just imagine the number of patients with severe atopic dermatitis who have actually thought of suicide. I know some people who attempted. I have known history of even homicidal attempts by atopic patients. We know that it is a terror. It actually robs quality life. Just imagine that nearly 1/3 to half your life is lost scratching and itching. And this scratching and itching leads to fights in families. And they always seem to be searching for a trigger or an allergen and do allergy tests and avoid this, avoid that. And basically, you end up with a huge impact in every phase of life. For example, if you take childhood, lot of quarrels, lot of avoidance of food and other things, lot of issues using creams and lotions and moisturizers. And we know that the quality of life robbed is not that of the patient alone, but of the entire family. We know that they're socializing in adolescence and sexual relationships, marriage, career choice, almost everything is affected in atopic dermatitis. And if you now look at this figure, and if you look at the quality of life in children, it is worse than renal disease, cystic fibrosis, urticaria, asthma, psoriasis, epilepsy, diabetes, acne. It almost approaches that of cerebral palsy. So it's obvious that we are dealing with a really terrible issue in childhood. Of course, frequent flares of atopic dermatitis are expected. It really has a very fluctuating course. And if you look at moderate and severe atopic dermatitis, and if you look at the duration of the flares, various studies have been there. You can see that nearly 27% of patients it will affect their school life with moderate atopic dermatitis itself, 45% in severe, and on an average around 33% are depressed, 39% have were teased or bullied. You can look at any kind of statistic. And regarding the family, 71% respond who have to be careful about what the child wears. The biggest issue in atopic dermatitis is very big fights in families. The parents will tell the child, your flower is because you are not, you didn't do that, you did this, you ate this, you did that, you went to for swimming. See, it's terrible. For 64% of responders that worry about possible side effects of their treatment, 63% responders that worry about the way their child look, and 52% responders feel that they have no control on their disease. See, they are all afraid of the side effects of the topical steroids many a time, and adherence and compliance. So the associations of atopic dermatitis need always to be factored in too, in the way we treat our patients. We now are beginning to realize that atopic dermatitis is a systemic inflammatory condition with possibly a huge impact on cardiovascular issues and other systemic issues also. The characteristic morphology of atopic dermatitis, like I said, wet and dry. So the healthy skin, the non-lesional skin, the lesional skin, and the chronic skin. So you have oozing, crusting, you have scratch marks, you have lichenification, a typical distribution and morphology, the classical essential important features, for example, the facial dermatitis in infants, the neck involvement, the body folds being involved except the armpit and the groin, the dryness and the xerosis, the associated features like ichthyosis, white dermographism, pityriasis alba, and the classical distribution in infancy, children, adolescents, and adults. We all know that it is more common in the face and neck, and the extensors in infancy, and then slowly moves on to the body folds, the neck, and then classically it settles down in the hand or as a head and neck dermatitis, and it becomes drier as the person ages. And we should be able to recognize the minor or associated clinical signs, the classical Denny Morgan's fold, a single or double fold below the eye which crosses the pupil when the person looks straight, the hyperlinear palms, the dry lips and the cracks in the lip, and lip-lick dermatitis, which is a common issue, and Queen Anne's or Hertog sign, where the lateral one-third of the eyebrow is missing because of constant scratching of the eyes, which might possibly contribute to the keratoconus also. And we need to be aware of the differential diagnosis of atopic dermatitis. In fact, the two things which are important in atopic dermatitis are to really know the Hanifin-Ricas criteria, because if you know the criteria, when I teach my residents, I teach them that you learn this because it mentions all the minor features also. So you will recognize and look for it. And at the same time, for example, the American Academy of Dermatology criteria, which aids and helps us to make a good differential diagnosis. The differential diagnosis depends on the age. Many of the audience right now, I believe, are pediatricians. You are pretty good, better than us at picking up immune deficiency disorders like Viscott-Ulrich and the other rare conditions like digestive
I don't know if you can hear me or not, but we are facing some technical issues. So we are trying to fix it in a few minutes. So please, in the chat box, tell me if you can hear me or not. In the chat window, below in the right corner, right bottom corner of the webinar screen. So you can hear me. Okay, perfect. In the control room, please try to fix the issue with Dr. Sri Kumar. And I can see that as well. The slides are not moving. So it means that we have a connection technical error with Dr. Sri Kumar. Just, I think, few seconds and everything will be okay and it will be solved. Meanwhile, we can again highlight that there will be a link. The link will be shared by the end of this webinar, and the audience can use this link to answer a few questions, and you should get a minimum score. And by answering these questions and getting the minimum score, you will be able to claim and collect the CME hours. So wait for the link by the end of this webinar. And for those who will not be able to do that after the webinar or who couldn't attend the webinar, the link will be shared again by email to all participants. Hopefully that everything will be okay in few seconds or minutes. And I think we can use this time in formulating some questions. So you can type your questions in that chat window as well. If you have any question in your mind now to be answered by the end of this webinar, we can use this time for formulating questions. You can ask questions about if you have managed before any case of atopic dermatitis and you have some questions related to the approach, the diagnosis. You can ask questions as well about the safety of using topical corticosteroids in the children. So you can type any question that you feel that it is related to the daily clinical practice. Okay, we have one question. Role of malassezia in facial dermatitis. Of course, malassezia is one of the fungi that is existing on the skin surface, apart from the skin microbiome. And the most common disease that is caused in dermatology is tinea versicolor. So I think this question will be answered by the end of today's webinar by Dr. Sri Kumar. Dr. Sri Kumar will come back. And I hope that everything is okay. You can.
Can you hear me now?
Yes, you can see you and we can hear you as well.
Oh my God, this was unexpected.
Yes.
So shall I proceed?
Yes, please.
Okay. So sorry for the interruption. I believe there was some technical issue. So in a nutshell, to recap what we spoke about, we talked about the fact that atopic dermatitis or eczema is the commonest skin disease, which is non-fatal and inflammatory, causing the biggest burden in the life of our patients. We talked about the prevalence of the condition across the world and the fact that it seems to be increasing. We talked about how we diagnose atopic dermatitis, which is basically based on a set of criteria. We actually looked at the clinical pictures, the morphology, the distribution in infancy, in childhood, and adults. We spoke a bit about the pathophysiology, the role of the genetics, the role of this epidermal barrier, the role of the microbiome, and the aberrant immune inflammatory response in the skin. And we actually looked at pictures of classical atopic dermatitis and the differential diagnosis. And I also presented one of my patients who actually ended up taking oral baricitinib with a good improvement in her quality of life in a relatively short period of time. So we came to this point where we are going to discuss about the treatment regimes. And when you talk about the treatment regimes, it's pretty interesting in the sense, okay. Okay. So if you talk about the treatment regime, the step one is basically to use basic treatment like hydration, emollients, avoidance of irritants, identification and addressing specific triggering factors. So basically, we need emollients and we need skin care throughout the life of atopic dermatitis patients. The big difference between emollients and, for that matter, the medications which are used topically, which are medicated, are that we can use them actually more frequently. In fact, we need to use them as frequently as possible, and they are the mainstay of therapy. But if this alone is not enough, we reach the second stage where we have a patient with mild to moderate atopic dermatitis, and we are in need of using low to mid potency topical corticosteroids and topical calcineurin inhibitors. So this is in fact the biggest bulk of atopic dermatitis patients, and we need to tackle many things here. We need to tackle steroid phobia. We need to have clear-cut endpoints. We need to have a discussion not only with the patient but with the family, and we need clearly to break through barriers of steroid phobia. We need to advise patients which steroid to use, how long to use, how frequently to use, how much to use, what to look out for, how to assess that it's effective, when to decide that it's no longer effective, and how to look for side effects. All these things are very important. So, of course, as the severity increases, for example, moderate to severe atopic dermatitis, we shift to little stronger steroids like the mid to high potency topical steroids along with the topical calcineurin inhibitors. If that is not sufficient, of course, we go on to systemic therapy. The interesting thing here is that as newer modalities of treatments are coming up, is this step therapy really required, and is actually jumping from one step to the other justified? And how do you actually evaluate and tell that a patient has actually not met the requirement of adequate cure and control? All these things are being debated, and this is really an interesting era. But I won't go into that in great detail. Insurance companies, of course, would love step therapy and not like to jump any of these steps. And we need to justify exactly what treatment we are planning for our patients. Of course, the basics of bathing. See, when a patient has severe atopic dermatitis, a bath is a torture. In fact, lukewarm water and a shower and using it for about 20 minutes and then adding bath additives, bleach and all that, they're all controversial. So emollients need to be applied when the water is still retained on the skin within 3 minutes out of coming out of the bath. And it is not very comfortable putting it on inflamed skin, and you need to actually reduce the inflammation with your topical steroids, calcineurin inhibitors before you use it. And treating the acute flare is very important. Of course, specifically, for example, coal tar, and now I believe crisaborole is also available, not in this part of the world, a PDE4 topical, which is a non-steroidal agent. So topical corticosteroids, calcineurin inhibitors, crisaborole, these are the three main topical agents. And when all this fails, of course, the systemic therapies. Antihistamines and their role is controversial. We used to use them more for sedation. The role of histamine as the cause of itch in atopic dermatitis is highly debatable, maybe very, very small percentage. The itch is more because of the immune inflammatory response in the skin, both the innate part and the adaptive part. We know that the Th2 response in the skin is predominant across almost all the spectra of atopic dermatitis, whether it is the normal skin, the acutely inflamed skin, or even in the chronic eczematous phase. There is a role for other immune responses, including the Th1, Th17, and Th2 pathways. But there is a good role for even the innate responses, including TSLP and alarmins, which are secreted by the keratinocytes. So itch itself is caused by not only the alarmins, but the interleukin-4 and IL-4, IL-13, and IL-31. And many receptors have even been identified in the itch nerves. And we know now that blocking the cytokine response has a huge impact in improving the itch of atopic dermatitis. So now we know that topical corticosteroids are probably the mainstay in the treatment of atopic eczema. 1950 or 52, in fact, when compound F or hydrocortisone first hit the market. And such a huge impact it has had. And in fact, the world has changed, I would say, before and after topical corticosteroids. And we know that as chemists, various modifications in the basic structure of topical corticosteroids have been done with a view of increasing the penetration, increasing the potency, reducing the side effect, and all these things. So all these gimmickry has led to actually a very interesting scenario. The 1950s, when we actually discovered compound F, the 1960s and 70s, when actually all these things like halogenation, methylation were done, which were done to increase the potency, but of course, with an expense of a lot of side effects. And then slowly from generation 1, generation 2, currently the 4th generation of topical corticosteroids, which are highly effective and have much less side effects. So in other words, they have a therapeutic index, which is absolutely fantastic. And very recently, not many advances have happened. In fact, the advances seem to be in other direction. But regarding the topical corticosteroids, once we reach the 4th generation, nothing much has happened. But the important thing here is that still a lot of practitioners are using the old molecules. And it is very important for us to be familiar with the 4th generation topical corticosteroids, because the therapeutic index is much better in these. And we need to know and we need to use a molecule which is actually highly effective and which is safe. So with this short introduction, let us talk about the therapeutic index. So the therapeutic index in the 4th generation of corticosteroids, see, many of these compounds actually during the first pass in the liver itself, they get metabolized. And the systemic effects, including the suppression of TP axis and all that, is very low. And when you look at these 4th generation molecules like methylprednisolone, acetonide, and mometasone furoate and fluticasone, these are having a very high therapeutic index with a very good clinical response and minimal side effects and minimal systemic side effects, topical side effects, and minimal incidence of sensitization too. So the therapeutic index is almost 2 when you talk about methylprednisolone, acetonide, and mometasone. Therefore, please do get familiarized with these 4th generation topical corticosteroids, because they are much safer and they can produce really as good an effect as the classical ones. So if you look at the classification of topical corticosteroids, we know that in the US, grade 1 to 7 is there, and in Europe and in UK, we have a mild, a moderate, a potent, and a very potent classification. And if you use this classification, you can see that methylprednisolone, acetonide, and mometasone, they're all in the potent class. So they are pretty potent topical corticosteroids. Of course, how do we choose a topical corticosteroids and how do we instruct our patients? See, there are many schools of thought. Start low and increase in potency. I don't belong to this school. I would rather prefer to start with an adequately potent topical steroid, reduce the flare, and manage the subsequent flares by preventing them with a topical calcineurin inhibitor, which is probably the ideal way to give a better quality of life for our patients. So it's much better to start with a really potent topical corticosteroids, but there are measures to make sure that we know how exactly to handle it. We need to counsel our patients that the fingertip unit is how we actually advise. The fingertip is actually an adult fingertip. The nozzle of most of these tubes are about 0.5 millimeters wide. And when you take one fingertip unit, you can use it on maximum 4 hand spreads of an adult palm. This is a simple way of remembering. Of course, you could use a chart in your clinic and put this for adults and for children, or even print it out and give it to them to teach them how much to use. But there are other ways also. For example, most of the potent topical steroids come in smaller tubes, 15-gram tubes. The milder ones may be dispensed in larger tubes. So even the regulators know how to regulate it. And we need to teach our patients not to use too many tubes and to have a control on the amount. Even more than 50 grams of a highly potent steroid for a week or so in a child can produce systemic effects. Luckily, even systemic effects do not produce a major issue, but still, in this era, we should not get into all this. Better to use a 4th generation topical steroid, which is potent, which has a high therapeutic index, use it appropriately, and teach our patients how to use what, where. We know the skin of the face and the body folds are more sensitive, and that special side effects can occur in the face. And we actually need to teach the patient how exactly to use it. So if you look at the efficacy of and compare this between methylprednisolone acetonate and mometasone furoate, actually an open label trial, I believe, was done. And in this, you can see that the responses with methylprednisolone acetonate compared to mometasone, and the percentage of patients who responded with a complete healing and marked improvement, you can see definitely methylprednisolone acetonate seems to be better than mometasone furoate. And if you talk about comparing methylprednisolone acetonate 0.1% to betamethasone 0.1%, again you can see that it's almost similar. Maybe betamethasone may be slightly better, but when you look at the speed at which methylprednisolone acetonate response, you can see right from day 1, day 2. So within a few days, there's nearly a 75% of patients meet the criteria for itch relief, even after 2 applications. And after the first application, mean reduction in itching was nearly 78%. And we actually see that when you compare the side effects, so if you talk about methylprednisolone acetonate causing less atrophy than mometasone furoate, you can see that the therapeutic index of methylprednisolone acetonate is much better. In fact, even visual assessment of telangiectasia is much less with methylprednisolone acetonate. So obviously, if you talk about the benefit-risk ratio or the therapeutic index, methylprednisolone acetonate scores much higher than mometasone, prednicarbate, clobetasol propionate, hydrocortisone butyrate, and betamethasone valerate. So it is high time for us to be aware of all these things. The baseline therapy is always very important. And when it is mild with a score rate of less than 25%, we need to use the topical corticosteroids and use calcineurin inhibitors in sensitive areas like the face and the body folds, and use it also as a proactive treatment to prevent flares, which is also true in moderate cases. And when you make a decision to use a systemic therapy, remember that very few agents are really licensed. In fact, I would say that probably Dupixent is the only licensed treatment. Cyclosporin is not licensed in the United States. It is licensed in in the European Union, of course. The phototherapy, I do phototherapy too. So narrowband UVB is the most commonly used one. But if you have access to UVA1, which is good for flare control. But phototherapy has its own issues. Time constraints and travel and cost and reimbursement. So many issues are there. Therefore, we actually need to be aware that the scenario has changed. Even though the scenario has changed, we still have to deal with topical corticosteroids, and we still have to be aware of topical calcineurin inhibitors. We should know which class we are using. We should know the limitations. We should know which kind of formulation we use on the face, neck, and body folds, hairy areas. We should remember that a long-term use of even 6 months can cause significant skin atrophy, and we need to be very careful even in these days. Of course, with mometasone furoate and fluticasone, rapid hepatic metabolism, and the systemic effects are much less. It is true for methylprednisolone acetonate too. Of course, we need to use the calcineurin inhibitors, which are molecules similar to cyclosporin, which cannot be used as a topical agent, but tacrolimus and pimecrolimus obviously can be used as topical agents, and their molecular weight is low enough for them to penetrate the skin to some extent. At least in inflamed skin, and tacrolimus 0.3% from the age of, all these are from the age of 2 to the age of 15, and 0.1% above 15, and pimecrolimus 1%. Tacrolimus can be used as a proactive therapy to prevent the flares. We can taper the topical corticosteroids down to weekly treatment if required, and we can use topical calcineurin inhibitors like tacrolimus twice alternate days or something, even over a period of 52 weeks, and we can actually successfully prevent the flares. And they are almost as effective as a moderately potent topical corticosteroids, and they are associated with much less impact as far as staph aureus colonization is concerned too. And there's no risk of skin atrophy, and they are non-steroidal. Of course, pimecrolimus too, and it's a little bit weaker, and at the most comparable to mild steroids. In fact, in one trial, less effective than betamethasone valerate. And there are no steroid side effects with these. Of course, a transient burning sensation can occur. So most of my patients, I tell them to keep the tube in the fridge and make it cold and apply it first, just to get rid of avoid the burning sensation. But most of the time when they continue, the burning no longer troubles them. Regarding the black box warning and the lymphoma, nearly more than 10 years of post-marketing surveillance has not shown any risk for lymphoma with these topical agents, definitely. Cyclosporin is only available as ophthalmic ointment or something like that, drops, not a topical cream. And regarding the systemic therapy, other than cyclosporin, frankly speaking, nothing else really works well. Though various studies have been done, the thing with cyclosporin is we need to use it as a crisis buster. And in reality, in real life scenario, people use oral steroids, short courses, as a crisis buster more commonly than, which that's not advised, definitely. It is something to be avoided. But in reality, that is what happens. And cyclosporin is, of course, still a major medication to avoid a crisis. But we all know cyclosporin, you need to check the BP, you need to be worried about the kidney, you need to be worried about this drug interactions. It's not an easy medication to handle. And in this COVID era, I'm not too sure that this would be a wise choice. Regarding the other medications, azathioprine, methotrexate, mycophenolate, mofetil, all these have, if at all, a marginal impact and a role, and none of them are licensed. So I don't want to talk about them. Rather, it's better to talk about dupilumab, which is a licensed medication for moderate to severe atopic dermatitis in adults and adolescents, and severe atopic dermatitis in children, which might possibly get approved even for people younger than 6 soon. So the scenario has changed totally, and we now are into the area of the biologics. So to put it in a nutshell, again to recap, we are dealing with 4 issues: a genetic predisposition, which is seen not only in mutations of filaggrin and other epidermal barrier issues, but also genes associated with a tweaked Th2 response. And we know that there is an impaired skin barrier, that there is an altered microbiome, with Staph aureus and maybe even Malassezia playing a role. We know that Staph aureus, when it predominates in atopic dermatitis, is associated with flares, and Staph aureus itself can act as a super antigen and can actually downregulate the epidermal skin barrier on its own and actually increase the Th2 response. So this is like a vicious circle. And we also know that the attempts at treating the epidermal barrier, attempts at altering the skin microbiome, attempts at doing something about the genetics have not all been very successful. The only target which seems to be really attractive is the immune response that occurs. And the immune response is seen not only in the normal skin, but also in the acute eczematic skin, and even in the chronic lesions in atopic dermatitis. The signature of the Th2 cytokines and the response is seen in almost all these spectra, including possibly all the genetic heterogeneous variants. Though in the Asian populations, a Th17 response may be seen, and a Th1 and a Th17 response has been identified in the chronic lesions. But still, frankly speaking, the main response is that of the Th2 cytokines. And of them, the IL-4 and the IL-13 blockade with the new monoclonal antibody, dupilumab, which can block the IL-4 receptor alpha, has proved to be a game changer. And if you talk about the Corona studies, there were solo and Corona studies which gave it the license. And in the Corona studies, actually, patients were permitted to continue topical corticosteroids. And when you add Dupixent or dupilumab along with the topical corticosteroids, your response is pretty impressive. And it's not only this. A plethora of monoclonal antibodies are in the pipeline. There are agents being developed against IL-13. There are agents being developed against IL-31. And the role of the alarmins, the TSLP and IL-31 in the itch of atopic dermatitis is being better understood. And we also know that many of these cytokines actually act through the JAK-STAT pathway. And a plethora of JAK-STAT blockers, like baricitinib being the first licensed one, and a plethora of new ones like upadacitinib and abrocitinib, and so many others are coming up. So we are in a actually exciting era, and I would like to say that I have a lot of patients on biologics in atopic dermatitis. In fact, more than 40 as on date. And in fact, one of my oldest patients was almost 4 years old. Almost as soon as it got licensed in the UAE, I was lucky enough to start a patient on dupilumab. So I would like to share an interesting 27-year-old lady with severe atopic eczema. I had seen her for nearly 15 years. Right from childhood, I had been treating her. She was having very frequent flares. She used everything: topical steroids, calcineurin inhibitors, moisturizers, antihistamines. She had got into the habit of using short-term oral steroids also. She ended up becoming a doctor herself, and she became an internal medicine specialist herself. And she really was fed up and reached a stage at the age of 27 when she started developing glaucoma because of frequently using steroids on her face, and also systemic steroids, which used to give her short-term relief. She refused cyclosporine, and she started actually isolating herself in her house, closed the door, refused to talk to parents who were shouting at her because they used to say, your flare is because you did this, you did that. Nothing was working. She almost became heartbroken, depressed, couldn't get married, couldn't meet the dream person of her choice. Well, the story is simple. We started her on dupilumab. I would say that within 16 weeks, there was a huge improvement. She had a facial flare, she had conjunctivitis, and in spite of that, in about a year's time, even her chronic lichenified skin lesions changed. We know that the blockade of IL-4 and IL-17 actually downstream even changes the epidermal barrier and even the microbiome. And the infection rate in these patients become quite less. And when we combine topical corticosteroids and dupilumab, we find really fantastic responses. And many of my patients have had life-changing results. If I tell the stories of most of my patients, almost all of them are really, I would say that, very rewarding patients. So she finally got married and she was fine. Of course, she had a facial flare. Why a facial flare occurs? There are a lot of theories, including the theory of Petrosporum furfur being a part of it. But I would say that the jury is out. We really do not know. Even though people try giving short courses of oral antifungal tablets, thinking that Petrosporum furfur or malassezia can cause a trigger, there's no proof that it makes any big difference in these patients. And I would say that we need to evaluate each and every patient very thoroughly and frequently. We need to recognize when actual, that is where the ADCT comes in, atopic dermatitis control test, where we can identify that the patient's control has been lost. We should evaluate whether is it because of a disease flare, a treatment which is not working, contact sensitization to an agent, are we missing some other diagnosis? Always revise the diagnosis, and revise the diagnosis. And I would like to end the talk by saying that thank you very much for having listened to me.
Thank you very much, Dr. Sri Kumar, for such a comprehensive presentation. And just a reminder for the audience, as we promised at the beginning of this webinar, here is the link for answering the question and claiming the CME hours. And before you go for the link, just a reminder, please type your question into the question box to the lower right corner of the webinar screen, and we will open the ground now for questions. We have some questions received from the audience, Dr. Sri, and allow me to push some of them first. We have received this question from Dr. Imran: the role of malassezia in facial dermatitis.
That's an interesting question, Dr. Imran. The very fact that you asked the question means that you are aware of it. So malassezia is one of the fungi which are increased in atopic dermatitis skin. So it's one of those things which clearly has been identified as one of the altered microbiomes in atopic dermatitis patients. And they actually set up an innate immune response in the skin, which probably triggers the Th2 response eventually. The interesting thing about malassezia is that there have been attempts at using antifungal treatments to actually reduce this flare, but the role is minor. Actually, we haven't ever seen anybody improving atopic dermatitis with an antifungal course, though people have attempted it. So other than the fact that probably it is an indication, I would doubt whether there's any therapeutic role in this.
Yes, doctor. I think we the malassezia is one of the microbiome, if you can say, the flora existing on our skin, the human's skin, and it can induce some fungal infections, superficial fungal infections. That's it. But I agree totally with you that it's very difficult to be found in atopic dermatitis. Thank you, Dr. Sri Kumar, for answering this question. I have personally a question which is regarding the steroid phobia. And from your clinical experience, doctor, how much percent of, if we can say, patients or patients' families, I mean the parents, are concerned about steroid phobia, and how can you approach those patients, the best approach to handle their concern?
Okay, I would like to answer it like this. I would say that 100% of my patients have a fear. Okay, because it's not just the steroid, but the fact that you have to use it for a long time. The first question that atopic dermatitis parents ask is, doctor, are you sure that by the age of 2 he'll be fine? Another doctor told me every year you celebrate the birthday, it will be less, and then by the time they become teenagers and all that, it's gone. So these are difficult questions to answer. See, we are not fortune tellers. There is no actually clear-cut test. There's no biomarker which can predict which atopic dermatitis will go away and which will keep on going to adulthood. And it is important for us to address steroid phobia in almost every one of our patients. The only good news is when a patient actually turns up to us, they are open to discussion with us. So I would say that a large percentage of patients disappear and they go for native medication, Ayurveda, homeopathy, and all that. This group, which doesn't come to us, is the one which has the maximum steroid phobia, and they need to be addressed with patient support groups and others talking to them, reaching out to them. But when a patient actually comes to us for advice, it's pretty easy for us. We always talk about steroid. We tell the patient two things. Of course, steroids have side effects. Of course, we need to make sure that we avoid two mistakes. using it when it is not required, not using it when it is required. And that is a mistake that we should avoid. Steroids are probably the only ones which actually gives a good relief to our patients. And we should remember that tackling atopic dermatitis is a priority.
Thank you, doctor. We have another question, which is regarding the long-term use of topical corticosteroids. Is this considered a cause for psoriasis?
The question is interestingly worded. I would like to put it like this. Can atopic dermatitis convert into psoriasis? The jury is out. Interesting, yes. There are some patients, especially with an Asian genome, where atopic dermatitis is there during childhood, and when they become adults, it turns into psoriasis. And there have been patients with atopic dermatitis who have been treated with dupilumab who ended up getting psoriasis too. So these are interesting findings. The percentage is very low. It is not true that a topical corticosteroid will cause a psoriasis. Psoriasis, we all know, has a genetic background and a triggering factor. And topical corticosteroids, especially the super potent ones, could be triggering factors. But when you use a topical corticosteroid and then suddenly withdraw it, generalized pustular psoriasis has been known to occur. In the US, they use topical steroids a lot for psoriasis. The Britishers are afraid. They don't advise topical corticosteroids in the management of psoriasis at all. So I would say that if you are ready to use other agents, if you are well versed with the use of biologics and cyclosporin and methotrexate, and you will be able to manage even a pustular psoriasis outbreak, do not deprive a strong topical steroid even for a psoriasis patient. But then if you are the type who cannot use a biologic and then are only going to use a topical steroid for psoriasis, I wouldn't recommend it. Of course, for atopic dermatitis and eczema, that's a different story. Topical corticosteroid is a triggering factor, not a cause.
Clear, Dr. Seri. I have personally a question, Dr. Seri, regarding atopic dermatitis. As you presented in the presentation, since 2018, now biologics are emerging and are used in the treatment of atopic dermatitis. However, in the last 2 years, there are many publications and clinical trials which used topical corticosteroids as a rescue treatment in between the use of biologics in the therapy of atopic dermatitis, which means that still topical corticosteroid with this long history since 50s still have a place in the era of biologics.
Of course. If you look at any of the trials of the newer agents, almost all of them end up with some trials as monotherapy. And then most of the trials have added topical corticosteroids and sometimes topical calcineurin inhibitors too. So if you look at the side effects of these trials, the commonest side effect will be a flare of atopic eczema. Okay, so that is interesting. So in spite of our current rapid knowledge and the increasing plethora of newer agents and biologics, we still need the topical corticosteroids, and we need to use them judiciously. In fact, when we counsel our patients, we need to be careful. Many of my biologic patients have reduced hugely their need for topical agents and topical steroids. They almost never touch antihistamines now. But still, I tell them that, look, you need to use them in addition to your biologic to give the best possible result.
Okay, so in the era of biologics, still topical corticosteroids are needed.
They are needed and have a huge role.
Yes. Question from another attendant to this webinar. Can use of sanitizer worsen atopic dermatitis? Wonderful question in the era of COVID-19, of course.
Hand dermatitis is something that we all see almost on a daily basis now. Probably you can publish, this is the time to publish about hand dermatitis and the incidence and prevalence in the COVID era. Hand dermatitis is, any dermatitis more commonly is irritant in nature than atopic. If you say the incidence and prevalence of irritant and cumulative irritant contact dermatitis is far more than atopic dermatitis. And an irritant sanitizer will definitely aggravate an atopic dermatitis. So I would like to answer it in two ways. Are you sure this is an atopic dermatitis? So we can't just make a diagnosis of atopic dermatitis in the hand just because somebody has a hand eczema, unless you fit in all the other criteria for atopic dermatitis. And the issue here is that we need to be very sure that we do not end up with aggravating our hand dermatitis by using hand sanitizers indiscriminately. That is not to say that you don't use it in this COVID era. That is only to say that you need to make sure that you use it appropriately. That's all.
Question from Dr. Muhammad Awad. I had one patient who was on dupilumab for 2 years, and it was very severe before starting it. But again, once he stopped dupilumab after 2 years of treatment because of fears during Corona time, it came back again with a severity less than before, but still ruining his life. How to proceed with such patients?
Okay. See, the thing is simple. When we start a biologic, especially dupilumab, when we counsel a patient, we tell them that, look, atopic dermatitis is a lifelong condition. You are genetically prone for it, and you have been blessed with it. And it is very important to keep it suppressed as long as possible, which means if you choose a medication like dupilumab, in fact, there's no endpoint. You are supposed to use it lifelong. Of course, this is theory. In practice, actually, I would say that even though the advice initially is supposed to be once in 2 weeks, which is the traditional licensed treatment, some of the trials with dupilumab had a once weekly arm also. My patient, for example, the one who got married during honeymoon, wanted to use it once a week because every 10th day, in spite of dupilumab, she was having a mild flare. Of course, when you stop it after using 2 years because of Corona and all that, and when it becomes less severe, it can definitely come back. So when it comes back, generally, so far in real world practice, if you restart the agent, it seems to be working as well as earlier. And the incidence of anti-drug antibodies are low. Of course, this is where your judicious use of topical corticosteroids and calcineurin inhibitors are important too. And you should be able to judge when exactly you would be able to restart the patient on dupilumab. So I would say that keep a file, keep your scores clearly, document the score, the EASI, the PGA, the anxiety scores, and the ADCT. And when you reach a point where the control has been lost and you feel that you need to intervene again, you can restart dupilumab. Regarding dupilumab and the vaccination and COVID, dupilumab is an immune modulator, and Th2 cytokines are primarily involved. This has nothing much to do with viral infections or vaccination. So it's a relatively safe molecule.
Clear, doctor. One question again is regarding dupilumab. The question is regarding the good improvement in a child with atopic dermatitis with dupilumab injection, but the child was having fear of needle. So the rest of the questions from the same participant is about if there is some formulations available other than the syringe with the needle, like the pen, to be used with kids, and how to deal with the fear of kids from injections, of course.
Okay, the answer is in two parts. First is, in my own experience, most of the children, my nurse runs a ring around a rosy, runs behind them, trying to chase them and catch them to give the injection because of the needle phobia. Parents also struggle and they try to catch and hold the child when we give the injection. This is a common scenario for the first injection, for the second injection. But by the time they have completed 2 or 3 injections, the massive improvement in the eczema makes them run inside and want the injection to be given. Most of my children, even those who had needle phobia, come for the injection once they have seen the impact of the medication. This is my own personal experience. Of course, research is being made and we can soon expect an auto-injector pen. I think it's well on the way.
Thank you very much, Dr. Seri. The last question, I think, tonight will be from myself, if you allow me again. We have the audience is actually from different specialties. We have dermatologists, we have pharmacists, we have pediatricians, and we have as well general practitioners. So my question is regarding atopic march. Of course, the patient coming with atopic dermatitis may have as well allergic rhinitis or may have bronchial asthma. So from your experience, what are the early skin manifestations of atopic dermatitis, which is an alarming signs that the patient should be treated, topically, or there should be a treatment for the topical manifestations? How could the pediatrician, the GPs get early alarmed about the activation or the flare-up of the disease happening in the skin?
All right. I would like to say that, the atopic march, the so-called atopic march, which starts with the dermatitis and then go on to develop the food allergies and then asthma and finally the hay fever. This has been written a lot in literature, but of late, research is saying that it's not exactly a march. The Th2 response occurs in not only the skin, but the nasal mucosa, in the esophageal mucosa, in the intestinal mucosa, and in the bronchioli too. And we all are aware of the so-called atopic dermatitis and the non-atopic atopic dermatitis with high IgE and without high IgE. But all these have become blurred in the research now. And currently, the thinking is that, you should be aware that these are all associations. And we have a huge list of comorbidities also. Rather than calling it as a march, I would say associations. So please be aware that the atopic dermatitis is one of the earliest manifestations. So once you see a child with an eczema, you have a candidate who is potentially going to have food allergies or asthma. And you need to be aware of it and treat it. Food allergy is something which happens only in early life, and even in a classical atopic, as they grow up, it sort of disappears. So the early diagnosis and the early treatment, the earlier you can control the skin flare, the better the outcome. The uncontrolled eczemas lead on to the atopic march, which is in the traditional sense.
With this, we came to the end of our webinar today. Before we close our webinar, I just want to thank Dr. Sri Kumar for his valuable participation in this meeting and for all the help and the guidance provided by you, Doctor, during the meeting. And I hope
I kept rambling as usual.
No, we really enjoyed the information and valuable information provided by you tonight. And I'd like as well to remind all attendees to use the link. We have shared the link now in the chat window, so you can either find the link in the chat window or later on we will share the link for CME reward via email following this webinar. And you will also receive a feedback survey following this webinar, and we really appreciate to receive your inputs. So in closing, it is really indeed to have you all tonight. And thank you again to Dr. Sri Kumar for his valuable participation, and special thanks to the organizers. And on behalf of Leo Pharma, we are looking forward to see you all again, and good night.
Thank you very much for the opportunity.
Thank you.